Bismillahirrahmanirrahim. Thank you, everybody. This is my disclosure. So my presentation today will focus on dual immunotherapy in the first line treatment of metastatic lung cancer. I'll talk about the treatment algorithm for first line treatment. I will talk about the options available. My focus of the presentation will be on checkmate in 9LA, which is a combination of a dual immunotherapy with a chemotherapy with a limited doses and cycles of chemotherapy, this is the interesting part actually. Little bit about economic data and then give a brief summary on my recommendation. So to start to talk about the cancer, lung cancer in Saudi Arabia, this is a table from Global Cancer Statistics, and it's a web-based platform. It's an interesting site. It's a global initiative for cancer registry development. I think it's an excellent site that you can reference it if you don't have an updated, an official cancer data from the official country registry. Maybe it has some limitation, but it works very collaboratively with many of the registry sites from many countries. So it gives you even updated registry. This is from 2018, and lung cancer considered the 8th most common in Saudi Arabia. Newly diagnosed as 923 patients, and actually mortality 779. So we already know that lung cancer have a very high mortality. The 5 years prevalence for all ages is 1,010. If we talk about globally, again, lung cancer considered very common along with the breast, colorectal, and cases registered, then the registries around 2 million. And if you look at the deaths rate, lung is one of the most
فاطمة الصوت مش واضح شوية.
الصوت؟
أيوة
Can
كده
you hear me now? This is better?
نعم.
If you look at the death, it's actually
في مشكلة.
it's very
دكتور فاطمة في مشكلة في الصوت عندك.
on devastating disease. Not only for patients, it's also devastating for the caregiver.
Dr. Fatma, can you hear me?
The left part, it shows you the psychosocially risk of metastasis and bad diseases, especially if the brain, bone, healthy quality of life. It has lots of interventions and lots of side effects, and also associated with disease morbidities because of the age and many side effects. The right part, it represents the caregiver burden, which is if you combine the moderate to severe burden, which is the dark green, the 48, this one 48, and the 25, it's actually around 75% of the caregiver experience some burden due to the lung cancer. So it is really devastating, not only for patients, it's also for the caregiver. Now, if we want to talk about the treatment options, in the far left, it shows you the patients with PD-L1, more than 50%. You give pembrolizumab, but we end up of having different treatment options if the patients have less than the 50% of the PD-L1. The treatment options can be chemotherapy, immunotherapy with chemotherapy combination, which can be atezo or pembro. And the last option is to give a dual immunotherapy. Dual immunotherapy tested in one trial, but the new trial is testing the dual immunotherapy with the chemotherapy. And this is what we're gonna discuss today. Now, a second line, if you discuss, usually if they progress in any of these options, you will go back to the immunotherapy or vice versa. Like if they don't receive immunotherapy in the first line, they receive it in the second line. If they didn't receive combined chemotherapy, they receive it in second line. Now we'll talk about the dual immunotherapy. Now it is approved and it's licensed and it's used, recommended in the guidelines to be used with the chemotherapy for squamous and non-squamous. If we go back and using dual immunotherapy history, as you see in the renal cell carcinoma and melanoma, it's showed a better survival with a hazard ratio of 0.6 if you combine nivo with epi versus tyrosine kinase. In melanoma, even it's a better survival if you compare it as a single agent, nivo and epi compared to nivo alone or epi alone. And the reason behind it, it's reflective in the immune response. Now, the first part is the mechanism where the CTL4 works, and the second part is the PD-L1. Now, CTL4 is cytotoxic T lymphocyte associated antigen, and the PD-L1 is the programmed cell death. They both work as as a negative regulatory for the T cell. So if you inhibit both, you have more activation T cell. This is just to summarize the mechanism. You will activate the T cell. CTL4 is involved in the initial part of the T cell activation, while the BDL is responsible for regulation for the TCL. So when you inhibit the CTL4 and the BD, together you have more stimulation and for the T cell activation. I'm sorry. For the T cell activation, which means that you have more T cell responsiveness as an anti-tumor immune responses. So in the beginning, there was, so if you combine ipilimumab with nivolumab, they work in a totally different sites. They both, ipilimumab, stimulation works in the initial part of the T cell activation, and nivolumab works in the regulation of the BDL, which is both. If you block again, you have more stimulation for the T cell. Now, we know that we have unmet need for patients less than 50%, and this is the group that really interesting and have lots of options. This is a slide which describes the duration of response. So if you have any BDL1, which is this part, you have an option of giving chemotherapy alone, chemotherapy, or chemotherapy with immunotherapy. Now, if you have a limited option courses of chemotherapy, patient cannot tolerate chemotherapy, for example, and you want to give a limited options, less chemotherapy, Pembro can be given only if the PD-L1 more than 50%. So this option will be very interesting for all PD-L1, squamous and non-squamous, and you give a limited course of CT of chemotherapy. And this is what we're going to discuss today. Our study. The monotherapy definitely immunotherapy.
Fatma, we cannot hear your voice.
It's higher efficacy than chemo alone. Now, if you combine immunotherapy with the chemotherapy, it also show a higher also showed this. Hello, can you hear me?
Yes, we hear you now.
But when did you lost me? In which slide?
Can you open the slides?
When did you lost me?
We lost you in the slides that comparing the chemo with the immunotherapy and in all
Okay.
150.
This one?
We can't see your slides. Can you share the
You
slides?
can't see my slide? Okay, just hold a second. Now?
Yes. You can open your slide.
I can see your screen.
Open
Just
the
hold a
PowerPoint.
second.
The PowerPoint.
I don't know where's the PowerPoint. Just hold a second.
Down.
Huh?
Beside the Zoom. Down.
You can see the Zoom icon, doctor.
Yeah, I open it, but I don't see where is the slide. Which slide? Do you see my slide now?
We see your email.
No.
You see my email. Okay. I'll put my slide here.
You can close it. Yes.
Okay, yes, now.
This is better.
Make it full screen, please.
Now it's good?
Yes, continue.
Yes, great.
Okay, so we'll go back on the first line treatment of lung cancer. You have an option of chemo with immunotherapy. But if you want to give a limited course of chemo, you have only an option of giving Pembro if the patient have more than 50% BDL1. So this new option will give you a choice of giving 2 immunotherapy with 2 cycles of chemotherapy only. I want to skip this slide quickly, just represent how much immunotherapy is effective versus chemo. And then immunotherapy with combination of chemotherapy is also effective than chemo alone. And then the side effects were not surprising. It's very comparable. If you want to start on our trial, is an nivolumab plus ipilimumab with 2 cycles of platinum doublet chemo versus only 4 cycles of chemotherapy in the first line treatment of stage 4 non-small cell lung cancer. It's called Checkmate 9LA. So this is the study design. The patients eligible if they are metastatic, they don't have an EGFR or ALK or any molecular alteration. You give only 2 cycle chemo with a dual immunotherapy versus a chemo, and this is included squamous and non-squamous patients. Choice of chemo, it depends on if it's squamous versus non-squamous, and there is an option of giving also maintenance pemetrexate after chemotherapy. The primary endpoint is overall survival. The secondary is progression-free survival and overall response rate, and efficacy by tumor BDL1 expression. This is the baseline characteristic. If you look at the BDL1, more patients have less than 50% BDL1 expression, and only 22 with more than 50, which is what we want to target. Really, is the patient with less than 50%. This is the treatment exposure, and this is my results. The overall survival by histology. This one with non-small cell lung cancer, non-squamous and squamous, and it's very clearly shows separation of the curve, not only separation and even plateau. The overall survival with 2 cycle chemo and dual immunotherapy is 17 versus 11.9 months, with a hazard ratio of 0.6 for non-squamous, and for squamous is 14 versus 9 months, with a hazard ratio of 0.6. The interesting part for these 2 curves, not only the separation, but also if you look at the after 2 years, the plateau, the curve really plateau, which means patient is still responding and they are not progressing. The follow-up was a minimum of 12.7 months. This one is the overall survival by subgroup analysis. The one that showed more survival with the hazard ratio of 0.3 patients with the CNS metastasis, which is very interesting. But they all favor anyway they all favor the combination of chemo and dual immunotherapy. This one is BDL1 overexpression. I mean, survival by BDL expression, and even without even looking in details, hazard ratio are all similar, and patients, regardless of the BDL1, responded to the treatment and have higher overall survival versus the chemotherapy. This is progression-free survival also is higher with a hazard ratio of 0.6. And this one is the overall survival for all treated patients. Patients' overall survival rate is 61 in 1 year and 43 in the 2nd year. And this, as you can see it clearly here. If you look at this one, 1 year is 63 and 2 years are around almost 50%. Now this one, the overall response rate is very interesting, and duration of response. The response rate, there is a double number of patients with complete response. Partial response about 36 versus 24, although you're giving less chemotherapy, and much less progression of disease with the combination. Duration of response is maintained around 11 months with a combination versus 5 months only with the chemotherapy. Now, this is the side effects. The left part, there is no surprises at all. The treatment-related leading side effect that lead to discontinuation. This little bit higher, 16 versus 5. But the deaths are equal in both groups. The right part is the kind of treatment-related selected adverse event with the combination, which is mainly related to the immunotherapy, skin around 36, and endocrine, gastro, which is, there is no surprises at all. Most of these side effects are grade 1 and 2, and grade 3 and 4 is only less than 5%, which is very statistically, I mean, classical with immunotherapy. So we don't have any surprises on the side effects with the combination regimen with the 2 cycles of chemotherapy only. This is selected treatment-related adverse event typically associated with the chemotherapy. This left part, we investigated the immunotherapy adverse event, and this one with the chemotherapy. As you see that we have more chemotherapy-related adverse event that could be related to hematological side effect, which is very classical, anemia, neutropenia, and thrombocytopenia. Now, this one, the health-related quality of life, patients received combination, they did better in the score with a hazard ratio of 0.6, which is statistically significant. And it's all the scores that's related to the lung cancer is favor the combination group. Patients, they do better in symptoms with the combination group. This is the health quality of life. Again, it's much better with the treatment combination. Now, the conclusion of the trial that overall survival improved significantly with a hazard ratio of 0.6 with the combination of dual immunotherapy and only 2 cycles of chemotherapy versus the 4 cycles or up to 6 cycles of chemotherapy in our study. Overall survival maintained for a minimum of 12 months with hazard ratio of 0.6. So this an option is used for non-squamous and squamous, and in all level of the BDL1. And there is no new treated-related adverse event observed with combining dual immune with the chemotherapy. Investigator concluded that this combination should be considered as a potential first-line treatment option, along with the other option that we talked about in the beginning of the study, of the presentation. This is trial-based cost to see. This is not a costing for comparing a chemo to actually immunotherapy. It's only comparing the adverse events cost, because we know that when we give more chemo, we have more hematological toxicities. And the whole idea about this combination is to give a limited chemotherapy of only 2 cycles with the immunotherapy, which is very well tolerated and has only a more frequent side effect of a grade 1 and 2. So they want to estimate 2 things, the cost per patient for grade 3 and 4 for the combinations versus chemotherapy. And what they want to also to compare the same cost if to another trial, like if you give a Pembro with chemo or Atezo with chemo from the Keynote trial and IM-130 trial. So if you look at the first objective, the side effect of combination of Nivo Epi with chemo versus chemo alone, it's definitely you have more costing associated with hematological toxicity that's given with the chemotherapy. This is why you have less cost in combination. This arrow means that we have a less cost, because especially in the hematological toxicity, if you give less chemotherapy, only 2 cycles. This is also the same in patients, and if you compare it with Pembro and also Pembro with chemo, you have more costs, squamous and non-squamous, because of hematological toxicity. And this one with the Atezo trial is also more cost saving if you give it again, because of most of the costs are related to hematological toxicities. Now this one, it's an interesting practice. This one summarized in a different way, summarize all the cost saving for the side effect. If you treat the patients in here, this is 2 cycles of chemo. You compare it with the chemotherapy, you compare it with the Pembro with chemo and Atezo with chemo. So you definitely have more cost saving if you give patients immunotherapy with the chemotherapy, only 2 cycles. So the light color is the combination of 2 cycle with dual immunotherapy. So you can see that you have less cost in managing the adverse event compared to chemo, or chemo with Pembro, or chemo with Atezo. And this is summary for the result. I just want to tell you about costing. There is many publications that it is very complicated to do costing analysis, like cost effectiveness in lung cancer, because treatment options are very, there is many treatment options and complicated. So it really was interesting for this abstract that show you only at least for adverse events management. Now this is a very, it's a good practice to see in our NEPCO if we have the same results. This is cost per patient, treatment cost for combination with or without 2 cycles of chemo. And it is really comparable to the immunotherapy. This is the median number of doses across the therapies. And if you looked at the table, we have the cost over here and different regimens over here. And cost of immunotherapy with the chemotherapy is really comparable to the other costs. This is data from our, from here, from NEPCO, from Saudi Arabia. This is a very nice practice just to see from our prices, is it similar or not? Because outside prices are totally different than here. Just a summary for my presentation: combination for dual immunotherapy with a limited cycle of chemotherapy have a survival benefit for patients in non-small cell lung cancer, squamous and non-squamous, and it's goes along with melanoma and RCC. That the dual immunotherapy are really effective. The recommended nivolumab dose is 360 over 3 weeks, and the ipilimumab 1 milligram per kg every 6 weeks with the 2 cycle of platinum doublets. And then you continue nivolumab with ipilimumab until disease progression. Again, with the comparing of costing of side effect, it's a very comparable costing, maybe even have more cost saving because of the chemotherapy induced side effects. And I'm done with my presentation. Thank you very much.